There we go. Okay, I'm here. So I'm the Chief Operating Officer and Chief Medical Officer of a small biotech that has 31 employees. We don't have any marketed products, but we hope that in the future we'll be able to bring a new technology to treat brain disease. This slide is cut off, but I'll read it to you. It's supposed to talk about the unmet need in ALS, and I think that every 90 minutes pretty much says it all. Every 90 minutes someone is diagnosed with ALS and someone dies with ALS. This is a terrible disease. There are 6,000 new cases a year in the US. It costs approximately $250,000 a year to look after someone with ALS, particularly because most of the care is terminal care. There have been 51 trials. I think there have been 50 failures, and need I say more. The timeline for ALS can't go fast enough because of the nature of the disease. And to borrow from Wilson Bryan's presentation this morning, he talked about first base, second base, third base. Well, we're in phase 3 right now, so we're on third base. And we've gotten to third base with singles. We haven't hit any home runs. We've gone one step at a time. So the technology's been in development for 10 years. It was licensed out of Tel Aviv University. A lot of smart people contributed to getting the technology to where it is today. This is our 4th study in ALS. The first 2 studies were open label studies. Again, similar to some of the rare disease examples that you saw this morning, where we wanted to see, is there an effect at all? Third study was a 48-patient randomized placebo-controlled trial in the US. I'm going to show you some data from that. And that was at 3 sites, Mass General, UMass, and Mayo. And we applied what we learned in our phase 2 trial to design our phase 3. And that's really what I want to talk about today is how do we make the study as efficient as possible to enroll the fewest number of people and expose the fewest number of ALS patients to placebo. Knowing that there's a lot of heterogeneity. And getting back to Emil's, I would have borrowed your heterogeneity slide. I think that's basically the name of my presentation. So what have we done about trial design? I put the colored Smarties on there as an example of heterogeneity. Essentially, because we don't have a biomarker, what we've done is we've relied on clinical characteristics. We had no choice. And the clinical characteristics are actually quite informative, and I'll show you some examples. They inform the prognosis, so they're useful for prognostic enrichment. They're useful based on what we learned in phase 2 for predictive enrichment, where we know who are the responders and who are not the responders. So within a development program, not between development programs, we can identify responders and in the next study apply what we've learned, and that's really what we've done. By using the rapid responders, and I'll explain to you in a minute what that means, we're also able to increase the study power quite a bit, so we can reduce the size of the study and the length of the study. And the way we identify responders is by having a run-in period, where we look at the rate of decline. So the run-in period serves 2 purposes. It serves to identify the group that we want to include and randomize in the trial, but also it's used as data in the trial because we look at pre-post slope changes for each person. And that actually reduces heterogeneity by 27% alone, even if we did nothing else. So again, it's about being smart. So ALS, as you know, is a terrible disease. This is an example of the ability of the rate of decline of patient function to predict survival. You can see that the arrow shows the rapid progressor group, and you can see the survival change in the rapid progressor group is fundamentally different. If you can imagine if you did a clinical trial and you randomly picked between these different cohorts, you would get very different outcomes, particularly in a study where for a disease where the average survival is 30 months from diagnosis. So we don't have the luxury of doing that. We really have to zone in on those who we think we can identify a change and those who we think might respond to change. Here's another way of looking at the data. On the left side, you can see the effect of reducing heterogeneity on the splay in terms of disease duration. So on the left, the pink and red are much shorter, narrower distributions of disease duration. On the right side, the slow progressors in green really go out forever. And again, it's critical. The most important thing in any clinical trial is the patient selection. And whether it's a biomarker, whether it's clinical criteria. And again, you can see the predictability in terms of the rate of decline on the right side, rapid progressors versus slow progressors. So if you have trajectory information, again, it's very, very useful, and that's what we've done. This is an example of diagnostic delay. In other words, people who are diagnosed early versus late. It turns out that for a disease like ALS, those who have lower diagnostic delay probably have clinical features that bring them to the attention of the experts, which probably leads to a more rapid decline because they're more rapidly progressing. They may, those with a more slower progressing disease may not be aware of it. They may not go and seek medical attention. So again, it's not double counting, but it's about being smart. Here's an example of data that you all have seen before. This is the riluzole data. There are only two marketed products for ALS, riluzole and edaravone, or Radicava. And you can see on the left side the outcomes of treated versus untreated riluzole patients. On the right side, you can see the rapid progressor subgroup. And rapid progressors are defined as a point per month decline on the ALS functional rating scale. So you can see that in one of the two marketed products, you can see that that effect is really quite profound. So again, what's the net effect of that? The net effect is that if you took 100 patients and treated them with this product, you would see in 1 year the clinical outcome that you would see in 2 years in an unselected population. Again, that's really useful information if you're doing a clinical trial. So we saw a very similar result in our phase 2 data. On the left, it's all participants. On the right, it's the rapid progressor subgroup. In this case, it was 0.7 points per month decline. And you can see that the results are really quite magnified in the group that excludes the slow progressors, which makes sense because people that aren't changing are very difficult to show a clinical effect of any treatment. Here's an example. Sorry about the color. This is my Apple PC disconnect, probably. But this is data that was shared by Origent, a group that's doing data modeling and simulation in ALS. You can see that looking at ALS functional rating scale, a 30% slowing or a 2.5-month survival change, you can see that the population required to show that change is much smaller if you select a rapid progressor subgroup. And obviously experts have remarked over the years that you can substantially reduce the sample size required for this. This could translate a number of ways. It could be a shorter study, or it could be the same length study, but higher power for the same population. Bless you. That was not in my script. But I'll take the pause anyways. So in our phase 2, we have a run-in period. We have a bone marrow aspirate where we collect the cells, process them, return them back to the patient, inject them by intrathecal injection, and do biomarkers before and after. We learned a lot about biomarkers in phase 2. They're not quite ready to be validated biomarkers, but we never know. In our phase 3 trial, we're getting 7 CSF samples. We think that we might be able to find a biomarker that helps in the future. The reason that the run-in period is very valuable, again, is because we can look at the slope before and after, which allows us to do a responder analysis. And I noticed that Emil showed very nice examples of responder analysis, looking at multidimensional responder analysis or even unidimensional responder analysis. So we saw a similar result. We looked at all participants and we looked at rapid progressors. This is the cumulative probability responder analysis, looking at all thresholds for responder, going all the way from 0 to 100%. You can see that the effects are more pronounced in the rapid progressor subgroup. Again, validating the approach of using clinical criteria as a clinical enrichment tool to make the study as useful and as practical as possible. So this is our phase 3 study, which we're conducting at 6 sites in the US. The 3 that were originally in our phase 2 trial, but additional 3 sites in California, because we did receive a California Stem Cell Agency grant, so we're trying to enroll California patients as well. So what we've done here is we've used the same run-in period where we have a 3-month run-in where we calculate the slope. Again, do the inclusion-exclusion criteria. People are then randomized. In this study, we're giving 3 transplants of cells that are modified, and the study duration is 28 weeks. We've restricted inclusion to those with a disease duration of less than 2 years, again, because we want to treat early. We are including rapid progressors only, in other words, those that are declining by at least a point per month based on the run-in period evaluation. It's the same evaluation that's done throughout the study, and is done on a monthly basis, and is done in person. It has to be done in a very careful way. And also, we're looking at pre-post treatment slope changes. So we're using the run-in period as an informative way of determining each person's trajectory. So to give you an example, if someone was declining by 10 points per month in the run-in period, if they were declining by 3 points per month in the post-treatment period, then that would be a significant change for them. Someone who's declining by 3 points per month in the run-in period, who then declines by 6 points per month in the treatment period, is actually getting worse. So I think heterogeneity really behooves us to find ways to manage it, because each person's trajectory is very different, and we do know that about ALS. So with that, I'm going to stop. Thank you for your attention, and I'll pass it on to the next speaker.